We're all okay on board, everybody?
Yep.
Yeah.
Yeah. Can you see me?
Yes.
Yes.
Yeah.
You managed to get the other
No,
tools working? No.
I'm working from my iPad.
Oh, okay. It should be all right, I think.
Yeah.
Mun
Okay,
Wai
we
not
can
going to
start
do his
already.
stung.
What is that?
Mun Wai was going to do a stung.
Yeah.
Yeah.
Okay,
Yeah,
so
the
are we
most
live
well dressed.
already?
Sorry?
Are we live already?
Yeah,
Yeah.
we are live. I
We're
think.
live. Huh?
Yeah.
Okay, good afternoon, everyone, and welcome to the Borneo Ophthalmic Surgical Symposium, or BOS. Over the next 1.5 hours, we'll be hearing 3 very skilled cataract surgeons speak on some very challenging cataract scenarios. There'll be some Q&A after each presentation. Please feel free to submit the questions in the comments box. If you're watching on Zoom and you want to speak, just raise your hand digitally, okay? May we request everyone to keep their mics and their videos off throughout the presentation. Okay, I'd like to acknowledge Dr. Ben Ho from the Eye Department of Sarawak General Hospital for his technical input and help with this webinar. Okay, so before we get on to the program proper, I would like to invite Dr. Dennis Kong, the organizer of this meeting, to say a few words. Dr. Kong is a consultant ophthalmologist and the founding medical director of the Eye Specialist Center in Kuching. Apart from a very busy private practice, he is also active in prevention of blindness activities in Sarawak. Okay, over to you, Dennis.
Thank you, Vicky. Good afternoon. Welcome to BOS 2020, where we started 3 years ago with the rather humble name of Kuching Eye Forum. I think it was a bit boring as well, so we decided to change it to BOS this year. I have a few suggestions from people that I should actually be calling it BOS School. And BOS School will stand for Borneo Ophthalmic Surgical Symposium, Kuching Utara, or Kuching Ultimate. I think we'll stick to a BOS this year. I think there are 2 main reasons why I wanted to start this symposium. The first is we in Sarawak always feel a little bit forgotten and neglected in some ways, especially when it comes to CPD activities. Not only in Sarawak, I guess Sabah as well, in Borneo or East Malaysia. So I guess the best way to get into the picture is to start a symposium or something that is ongoing, perhaps annually. The second reason why I started this is because I believe that video is the best way actually to learn, one of the best way to learn surgery. You know, you have heard the phrase that a picture speaks, a picture is worth 1,000 words. I would say that a video is worth 1,000,000 words, especially when it comes to learning surgical skills. Of course, you can say you can just go on YouTube, but the problem with YouTube is very often there's no commentary, and the video could be sort of very heavily edited that it looks too easy, and it is not. So I think this is a better platform to learn surgical skills. A surgical symposium in which you later on, it is interactive. All participants are encouraged to ask questions. Without further ado, I'll pass the meeting over to Dr. Chin. Thank you.
Okay, thank you, Dennis. Okay, now we shall start the presentations. Our first speaker today is Dr. Lee Mun Wai. He is the medical director and consultant VR surgeon at the Lee Eye Center in Ipoh. Dr. Lee is well known to us as a popular speaker and as an experienced cataract surgeon who has performed live surgeries at international meetings, including the AP-ACRS. He will speak to us about the options for managing capsular problems. Over to you, Mun Wai.
Hi, good afternoon, and hello to the panelists, and thank you, Vicky, for your introduction. So I think all of us have been having an overdose of webinars during this MCO period, and this is yet another one. And my thanks to Dennis for involving me, because this is indeed, I believe, I echo his thoughts in the sense where, especially when it comes to surgery, you know, nothing beats the video. I think we learn a lot from each other during these symposiums. So I'm going to start off by sharing my screen. So today, I think I have the privilege of speaking to all of you just a little bit about capsular problems. It's just going to be an overview. I'm not going to go into too much details. There will be some videos, of course, and to show some of the problems that we will encounter as we take on phaco surgery. I think phaco is our bread and butter, and whether we are junior or senior, it doesn't matter, because if we do enough, we are always faced with complications. And complication management is how to actually be able to save ourselves in the sense where we can actually convert a bad situation into at least one which is not so bad. So you'll see here, these are my own cases where these are moments, Homer Simpson here goes, whoops, where you actually busted the capsule, and these are not planned, obviously. So these are actual cases where I have inadvertently, usually in the last piece over here as shown here, perhaps the video can't see so well, where you actually get the upward surge of the capsule and you get a little hole there. So have when we actually do phaco, and if you look at some of the studies, it's not just posterior capsule, the anterior capsule, of course, is also something that will go on us, and there are lots of papers and studies, and the percentages as quoted here fortunately are not too common in occurrence, but as we move through from training from junior to senior, we will find that our rates, well, should anyway get low and hopefully be 1% or less. So anterior capsular tear, if you look at some of the papers or even with our own experience, most commonly occurs during the CCC and before phaco. So those are the most common time to get anterior capsular tears, of course. You can, of course, do that as well when you're phacoing, when you chom a bit of the anterior capsule, but the studies have shown that almost half or 2/3 of the time, it will be during the time before you even start sculpting. So what happens when you get an anterior capsular tear? So it then compromises the subsequent steps in the phaco surgery. And these papers have shown that you get PCR in a quarter of the time, resulting in vitreous loss, drop nucleus, which is of course horrendous for everyone. And a lot of the time they require secondary surgical procedures as well, be it either to then put in an IOL or maybe to clear vitreous again or further reposit iris, etc. And a lot of the time they end up with poor refractive outcomes because it's all unplanned and everything is being done under a stressful situation. And rarely, but still significantly, they do end up with significant or permanent visual loss in some cases. So some of the cases where you might want to beware, where you might get some inclination to think or to prepare for a potential problem is when you have this is not exhaustive list, but some of them I've highlighted. If you have an intumescent cataract, you have zonulitis, pre-existing, a shallow anterior chamber, and angle closure glaucoma types. You have an anterior capsular plaque, or very elastic capsule, perhaps in the very high myopes or in some of the younger or pediatric cataracts. You might be able to prepare for not an eventuality, but a potential for problems with the anterior capsule. So in the antimonsen cataract, I think this is something that, well, I've had my fair share of this Argentinian flag sign, obviously. So where you get the actual extension of the whole anterior capsule. And really what you need to do is to put a heavy molecular weight viscoelastic to sort of tamponade all the cortical material so that you get a concavity of the anterior capsule and subsequently then aspirate the cortical material before you move in to start puncturing the capsule, because it can happen very quickly. Over here is just a device that I've tried before. I think it's fairly useful. I don't use it all the time, but when you first start using it, it's actually a silicone ring, which you can actually put onto the anterior capsule, and it gives a little bit of a barrier for you to guide your anterior capsule while you're doing it, particularly in situations where you might anticipate a run out. It does not formally act as a very strong barrier, but it's some form of a guide as you're pulling your rexus around. It does actually allow a physical guide there, aside from just doing it freehand. So intumescent cataract is something that you have to be aware of. Now, this is described by Brian Little. It's not something new. It's just a reminder. And this video is a bit dark, but you will see that when you are doing the rexus, a lot of the time it happens when either we are just complacent, or it can happen when in situations where you're pulling and shearing or ripping the rexus with a forceps. In this case, could be with a needle, and you'll find that the rexus is going out. So Brian Little has described this long time ago, and it's a very useful technique. And I think to remind everyone that sometimes we do it subconsciously because we're so familiar, but what it actually does is very important. So what actually happens is, just a little repeat here, is when the rhexis runs out, you try to grab the edge of the rhexis nearest to the point where it is running out and pull centrally towards the center of the nucleus, and you help to bring the rhexis back in to your within your control and complete it. Obviously, then you will lose the full circularity of it, but at least you don't have a wraparound tear as it extends all the way to the equator or beyond. So just remember to pull it near the edge where it's going and bring it back to the center. Now, it may not happen in all cases where it be successful. If it goes beyond what you can see or beyond the equator, then it won't come back. So in this case is when it actually happened. This is a traumatic cataract where you have some corneal repair there and there's some posterior synechiae. So over this part, when I'm actually pulling, you see the whole actual, where the red arrow is, the whole actual rhexis goes beyond the pupil edge. Yes?
Man Wai, are you sharing screen now? Because I'm only seeing your face.
I am sharing screen.
Oh, I see.
Oh.
Can the others see Man Wai's screen? Yes, huh? Oh,
yes,
okay.
yes.
So maybe. Oh, all right, all right.
I can hear
all right, carry on. Sorry. Yeah. Sorry.
No problem.
I only see your face,
so
Man Wai.
I was just. Oh dear, is it because of your iPad?
Maybe. Okay, never mind. As long as other people are seeing your
I'm
screen,
showing the video
okay.
now.
Okay, I'm only seeing your face.
So,
all right.
In this case where the actual rhexis has gone beyond the equator, I feel, so we try and complete the rhexis from the other side. So I take either a micro scissors or a small fine long end Vanna scissors to cut the capsule on the other side and try and complete it that way. As you can see, having completed the case, the rhexis actually gone beyond what I could see, perhaps not fully beyond the equator, but was safer to complete it from the other side rather than to try to do the little maneuver and pull it towards the center. So visualization is important. So this is another sign that actually has been described by Rohit Prakash, which is an Indian colleague and group, where he talk about flat motility sign. I think a lot of you might have already read it. It's not that new, but he has been talking about it at the regional meetings, which I think has been a useful sign. When you get an anterior capsular tear, particularly what you look for, if you can see, this is a diagram that shows it, where, excuse me, the anterior capsule is actually everted, or if you hear him present, he talks about it fluttering in the wind, where you have, you're doing your phaco and you have fluid influx, and you can see the flaps flapping around. So that indicates that the actual flap has not extended beyond the equator, and it's safe in this case complete your phaco, but obviously slow-mo manner. Now, on the contrary, if you notice that the flaps are actually plastered down onto the anterior, onto the lens surface or inverted, and then he says that it's probably best to convert, because if you continue and manipulate within the bag, this likelihood is that the actual capsule, the capsular tear will extend to the posterior capsule and you might get a drop nucleus. So the details of all the mechanics of how he describes how he came up with this sign is actually described in this paper, so you could have a read. So if in doubt, as I mentioned, convert, because there's no shame in actually doing an ECCE. I mean, it's a technique that we have all learned, and well, for those of us that are more senior would have learned it, but I'm not sure whether the more junior surgeons coming through will learn doing as much ECCE. But converting is not really something that you should frown upon, because it can still help you out in certain cases where you just cannot phaco anymore. And there are papers as early as 2015, as recent as 2015, has talked about the fact that in general, converting to a manual cataract extraction is still a valuable surgical option. So particularly if you and it's not safe to continue. No shame in that. Just to now, switching gears a little bit to the posterior capsule, which is of course the bane of our phaco, the existence of phaco surgeons. So this is a paper from Singapore. They looked at a large series of their own cases, a 5-year audit, and they looked at when PCR occurs most. I think we all know that it happens during phaco, happens during INA. So in this case, the frequency is 60%, well, 85% of the time in this series, it happens during these maneuvers. So what are the scenarios where we want to be a little bit more careful about posterior capsule? Of course, posterior polar cataract is famous for that because we know it's a thin capsule and perhaps even a defective capsule to start off. So there are different maneuvers, and you can hold symposium talking about how to manage posterior polar cataracts. The post-vitrectomy cataract is something to be aware of because us retinal surgeons are rough when we go into the back and we don't care too much about the lens you might have jabbed into the posterior capsule. So when you do such cases, be prepared that the capsule may be defective. Previous intravitreal injections, now we're giving a lot of that. So obviously when we do injections, the idea is to avoid the lens, but sometimes, it happens. You can actually puncture the posterior capsule and get problems when it comes to doing the cataract. Traumatic cataracts, of course, is something that can, of course, have a posterior capsule defect to start with. Now, recognition of early problems during your surgery is key because that allows you to then plan or at least come up with some form of a plan during surgery to manage complications. So this is an example of a pupil snapshot, again, well described during hydrodissection, where you get this sudden explosion of the posterior capsule and then you get this rupturing of the capsule. So in this case, it's probably perhaps not wise to continue phaco. You may need to convert. So you look at other signs that have been described about difficulty rotating the nucleus, reduced followability of the nucleus as you are phacoing with no problem, and suddenly you find that the pieces are not coming, or of course tilting of the nucleus. All these signs are just some things to remind us to look out for things even when we don't expect them, because things can happen during surgery. Now, when you do have a problem, this was an earlier case when I showed in the first video, one of them where the last piece, when I removed the capsule, came up. So when you get a little small rent, and this is annoying because, or you've done the job well, and then you just need to put the lens in and you're done, and you put a little hole in the capsule. So that all is not failed yet. I mean, in some cases now, in this case, I've done a posterior capsulorhexis. The reason being is, as we do more and more of these so-called premium lenses, multifocals or torics, sometimes if you can get a lens still in the bag despite a complication like in this case, I think it's still very useful, especially when the patient is expecting either a multifocal or a toric. So in a small enough rent, as in this case, I think completing it with some microforceps and putting enough viscoelastic to create space and stabilizing the eye and finishing off so you get rounded edges while you put the lens in, is actually stable enough to take a lens in the back. Of course, the alternative is just to put a 3-piece in the sulcus and optic capture. That's still a very safe alternative, but I mean to actually have in cases where you can still use the lens that you plan to start out with in cases when you do have a complication. Management of vitreous is again a whole other topic that we can talk forever on, but it is an important skill that you need to have and to understand the principles behind vitreous management and to do them safely and effectively. So this will always bail you out, because what the worst thing is to have vitreous left behind or not manage the vitreous properly to end up with retinal complications later. So you can see here my routine now. This is not a complicated, this is an example I showed where this is subluxated cataract, but visualization is important. Use of triamcinolone is very useful to show where the vitreous is. Sometimes it's where places where you don't expect. And I do it routinely as a pars plana now, anterior vitrectomy, because it is actually the most, I find the most effective and efficient way, as well as a logical way of doing it, because you're removing vitreous and cutting off from the back rather than trying to pull it forward from the limbus. So just remember, you need to maintain a closed chamber. So over here you see there is the main wound is, you're not going through the main wound, so that they have an anterior chamber maintainer to maintain the closed chamber and carry out the vitrectomy safely. So what happens to the IOL when you've busted the capsule? So there are a lot of options. Anterior chamber IOL is something that we still use, and I think it still has its place. I'm not a big fan of anterior chamber IOLs, purely because it's only something that we will consider when we run into complications. And I think not many of us will keep a large consignment of anterior chamber IOLs, or will have an anterior chamber IOLs to stand by for every single case that we do, because it's not something that we use all the time. Now, the problem with these is if they are not sized properly, I think they can cause problems. If you have a good sizing, the white to white is good, everything is good, it stays very well. Like in this case, it's a very nice anterior chamber IOL that can stay on for many, many years. The problems I've had over the years is come across where anterior chamber IOL does not fit well, it vaults too far forward, or you get stuck in the angle, you get glaucoma, corneal issues. I'm sure YY afterwards can talk about all the kinds of corneal problems you get with anterior chamber IOLs. This is another example. This is a newer one. This is the Artisan, where you can do an iris clip. I've used a couple of those. Again, not a bad option, but this is usually something that you have to do as a secondary procedure because you don't have these on consignment. You have to order these. And when you order them, then obviously you need to tell the patient that you need to come back on another day for this procedure, and there's a bit of inconvenience there. And of course, it needs a large wound to put in. It's not small. We need a 6mm wound to actually get this in. So sulcus IOL optic capture, this is again very vital, but not too difficult, but a vital skill that you should have and be aware of. Not a great video here, I'm afraid, but that's the PCR. And in this case, it's not small enough for me to do a posterior axis, so I'm going to switch to a 3-piece IOL. The idea is to create space in the sulcus, put a lot of viscoelastic between the iris and anterior capsule, put the lens into the sulcus and dial it in that way. But after having dialed it in, to get the IOL stable, you then push the optic through the anterior capsule. So there comes some merit in not doing your anterior capsule too big. Mine's around about 5.5mm. Some people go smaller than 5. So you got to get a balance there so that when you do run into trouble, you can do an optic capture safely. This is a document. It might be a bit small here. This is from Warren Hill. Is a guru in biometry that we all know about. So this is a document that I did not know of at first, but have come to learn more about as I've heard him talk about more and more. And you go to his website, drhill.com, you get lots of very useful information and very helpful tips to manage biometry problems. So what is this chart here? This chart is present in my operating theater. So it actually tells you the calculating back versus sulcus IOL power. So as we know, if we actually plan to have a maybe 20 diopter 1-piece IOL in the bag, when you have a capsular rupture, do we then put the same 20 diopter 3-piece IOL in the sulcus? So all that comes in besides the A constant, and we know about the importance of effective lens position. So this chart here very quickly allows you, without having to do calculation, and it tells you straight away what lens power you need to put in the sulcus. So it's all listed here. The higher the power lens you're putting in, the bigger the difference or the reduction in the power of the lens you need to put for the sulcus power. For example, it's a 30 diopter lens. So the back sulcus difference is 1.45 diopters. So you need to subtract 1.5 diopters from the 1-piece. So you need to put in a 28.5 into the sulcus if you had a 30 diopter lens. And if the lower the power, then the less the change. So you see over here, if it's 9 diopters, then there's no change in the power. So this is a very useful thing. So if I have run into a complication, I can have this chart to refer to without having to think about, deducting half a diopter, 1 diopter, and things like that. So this just gives you a better refractive outcome, even in a complicated scenario. So this one, reverse optic capture is another technique which actually, I think what Dennis mentioned earlier is correct. A lot of the time it's made to look easy, but really it's not that easy to do. Reverse optic capture, I've done it in a couple of occasions, fortunately not too often. And this case is where I needed to put in a toric IOL, and of course did not do well in terms of busting the capsule. But the anterior capsule was small enough. So what you actually do now is to put the haptics into the bag, or rather into what's left of the bag. So the haptics are actually in the vitreous, you can say, but the optic is above the anterior capsule. So in this case, you can still align the IOL to the actual alignment that you want in this toric IOL, but it is captured in the sense where it can be stabilized, and they do reasonably well, but it's not really a scenario that somebody is comfortable doing it. Then just put in a 3-piece, then you got to correct the astigmatism later some other way. Coming to the end towards now, if you run out of bag, you busted the bag bad enough that you can't save it, then you can end up needing to do sclerofixation. So whether you do it as a primary procedure or you want to just close up, finish off, and then tell the patient you come back and do it secondarily, I think later on, Dennis and YY will talk about other techniques, but I'm not going to go into detail. Sclerofixated IOL suture has been the box standard. You can go ab internal, ab external. People have done this with Gore-Tex sutures now rather than Prolene, and use the Acryos lens with the 4 eyelets. There has many techniques that have been described. But more so in the last decade, since Gabor Shariath talked about the intrascleral fixation, I think this has been the trendy thing now. Everybody looks to do things better. I think this is a better way of doing it, but you need a 3-piece IOL and putting it into a tunnel in the sclera to stabilize it. Glued IOL has been described well by Ahmad Agarwal and group, and I think this is something I've not tried because I find using tissue glue is not really the cheapest option for my patient, and I don't really have that readily available. But intrascleral fixated IOL, my standard go-to technique is the Yamane technique, as highlighted here, the principles of which I will allow Dennis to talk to you about afterwards. He's got a whole talk about it. But essentially, you're using a 3-piece IOL where you can then fixate, exteriorize the haptics with 30 or 27 gauge or 26 gauge needles in some cases, and then subsequently using low heat cautery to create a little nubbin or flange at the end of each haptic, so to prevent them from sliding back into the eye. And this has worked well. I've been doing this for 4 years coming up, and got very good stability in these cases, and it's a great technique. But again, with any good technique, there are always pearls and always certain things that we need to do correctly to get good results. So really, I think coming to the end now, just a few things to give you an overview of capsular problems and how you can manage them. And really, hopefully, when you do encounter these types of moments in future, you're a little bit more prepared, and you can actually review back on some of the things that have been said here and just remind and safely. So remember now, just remember to recognize early recognition is important. Slow down yourself, take a deep breath, have a plan of action, and remember to manage the vitreous well and decide how you want to do the IOL, be it at the second sitting or at the same sitting. It depends on what you're comfortable with. So thank you very much. And my thanks again to Dennis for allowing me the option, the privilege of being part of this symposium. And you are the boss. Thanks, Dennis.
Vicky, you have to unmute yourself. I think there's a question from the participants.
Yeah. Thank you, Man Wai, for the nice talk. Okay, there's a first question from Jane. She says, Man Wai, do you perform anterior vitrectomy after posterior capsulotomy? And can you put in a toric IOL?
The answer to the first part is basically depends really. I think you've got to assess whether you have vitreous loss. And a lot of the time, if it's just a small little puncture as right at the end of the case, you don't get vitreous loss. And if you don't have any, then you don't need to. So do you put a toric IOL? Yes. I think that case wasn't one, but yes, you can put a toric IOL into the bag. But again, it comes down to your own comfort level and how you're going to manipulate that lens within the bag. Now there's a little defect there. So therefore, it's important to obviously get a nice round CCC so you don't have all those potentially extending edges to, during your manipulation within the bag.
So Man Wai, when you do the posterior CCC, when you convert a small PC hole into a posterior CCC, do you use the same Utrata forceps, or do you convert to a micro forceps? Because sometimes when you have to dig quite far down, you can distort the cornea and cause striae. It's hard to see. So what would you advise?
Right. I think using a micro grasper is easier. So there are quite a few available. The ones that I have is the MST. The MST has got a nice set of micro instruments. They have micro graspers and different types of micro tips, forceps, and even scissors and IOL cutters. So they come in a set. You can buy different things and use that. It's easier than to use a Utrata, because like you said, the problems are obviously distorting the cornea, and then you don't see well. So a lot of the time you need something that is smaller.
Yeah, that's quite a practical problem actually. Doing a posterior CCC may not be always as straightforward, especially if you have already got some problems. Yeah.
Yes.
So the micro grasper, I do agree, is helpful. Do any of the other panelists have any comments or questions? Okay, let's say, Man Wai, I ask you again. If let's say you make a nice anterior CCC, and then as you're phacoing, it suddenly turns into a keyhole, like a big keyhole, how would you orientate your lens after that? Do you have some tips for the trainees maybe? what's a good position to put the lens in relation to the keyhole?
If it's just a little chomp, I think I've done it before. You know, sometimes you come a little bit too anterior and you chop a little small hole and you can still see the edge there. Then a lot of the time I find that that's okay. You can just leave it because you can still see the round edge. Now, if you see in that case where I went out, where you can't see the edge of it, like you say, it's a keyhole, then I would normally try to put my haptics around that meridian to see whether you can support it a little bit. But I don't think there's any one way to prove that it actually works better. But I would tend to try and put things over to the area where there's a potential defect to see whether you can support it a little bit better, rather than stretch it in the other direction and put a little bit of stress on it.
Can I ask, Mun Wai, what needle do you use when you do the Yamane technique?
I use a 30 gauge. I actually started with a 27 gauge because the 30 gauge that we use for intravitreal injections, the bore is too narrow to fit the haptic. So I got hold of this thin-walled 30 gauge needles online. I bought them. It's actually somebody from America. These are actually dermatology needles. They use them to actually inject in the skin for those cosmetic procedures. So yeah, I got them online. They are 30 gauge.
I see. Yeah.
So your go-to, your backup is actually a 3-piece, and you would do a Yamane technique fixation if necessary. So do you have that kind of a 3-piece IOL with the haptics there on standby in your OT? The range of the Zeiss lens with the haptic that you can easily make a little knuckle?
No, the Zeiss one, unfortunately, you know, it's difficult. You have to order them and they don't give it to you as a consignment. But that's the best one because they don't have PMMA haptics. They have a polyvinyl difluoride. I think very, very sturdy. I think Huawei will show how strong they are. But the ones that we do have, the standard 3-piece, we have the Alcon has one and J&J has one. And I think there are others as well that will actually have a 3-piece. So as a standard, I have a consignment of 3-piece IOLs in the OT so that if I do run into problems, they're there. But if I have a problem, usually I try to sort it out in the primary setting and clear around the vitreous. If I can't save the bag, I will put in the IOL at the same sitting with the Yamane.
Yes, okay. There's another question from Jane. Optic capture, can it be the other way around? For instance, the optic inside and the haptic in the sulcus.
Well, if the haptic is a PMMA haptic, like what I did in the first one, the standard sulcus IOL with a optic capture, that's fine because we know the PMMA haptics in the sulcus won't cause too much problems. Now, if however is a 1-piece, that's why when I show the reverse optic capture, you don't want to have 1-piece bulky, this kind of acrylic haptics in the sulcus because they've been shown to cause a lot of UGG syndrome and a lot of pigment dispersion. So that's why you end up with a reverse optic capture in these cases. You put the optic above the anterior capsule and your haptics in the bag.
Okay, yeah. One last question for Mun Wai before we move on. Dr. On Hong Liu wants to know, as a VR surgeon, would you prefer the IOL to be implanted before we send you a case of drop nucleus?
No. For me personally, I prefer not to because I find that in general, I think the IOL tends to get in the way. Sometimes if it's a dense nucleus and I can't remove it safely or frag it safely, I feel I might want to bring the nucleus forward and the IOL gets in the way. Sometimes if there's vitreous, some areas that needs to be managed, then the IOL again has some issues as well. So in a lot of times I say, if you can just do a nice vitrectomy or clean up as much as you can and leave it aphakic.
Okay. All right. Well, thanks very much, Mun Wai, for the lovely lecture and all the answers. Okay, now we'll go on to our second talk. Our next speaker is Dr. Choong Yean Yaw. He's a corneal specialist and anterior segment surgeon at the Tun Hussein On National Eye Center. And Dr. Choong is actively involved in teaching surgical skills and to trainees. And he also does a lot of voluntary eye surgery. He will be speaking on how to manage a subluxed IOL. Over to you, Yean Yaw.
Good afternoon, everybody. Can you see my slide? Thank you, Picky, for the
Yes,
introduction.
yes.
And thank you, Dennis, for organizing this webinar. I think for the last couple of weeks, most of us had so many webinars until we get fatigued on joining the webinar. So I'm very glad to see that there are still so many participants in this webinar. So I'll try my very best to share with you my topics, which is the management of subluxated IOL with you, so that hopefully you can have a lot of take-home messages from this talk. This is my financial disclosure. Now, I think most of you will agree with me that we are seeing more and more patients coming in with subluxation of intraocular lens. I think the reason is because, many of these patients had IOL in the lens for many years already. And, in my practice, my experience is that the most common cases that come in with subluxation of IOL are those patients likely to have some sort of complication during the initial surgery. And likely also, and more frequently, I see them, they are the case of post-phaco surgery. Now, in my experience, I just feel that, when we do a phaco surgery compared to ECCE, phaco surgery is actually a lot more controlled procedure. Years ago, when I performed ECCE, when I express the nucleus, sometimes, you may have a surprise that not just the nucleus come up, but the vitreous also came up together. And frequently, it came up through a large division of the zonules or a large PCR. That is, after that, it's difficult to put any lens into the bag or into the sulcus. Most of the time, it's an AC IOL that's implanted in those days. Well, when it comes to the phaco surgery, what I'm saying is a very controlled procedure. You see, most of the time, I think, even if anterior capsule tear or posterior capsule rupture, if you do it properly and elegantly and in a gentle fashion, likely that a lot of surgeons still able to implant the lens into the bag or into the sulcus. Now, most of the time, the lens appear to be okay with no problems. Okay. Now, with time, unfortunately, with the capsular bag contraction or gradually, weakening of the zonule, some of these lens may be displaced and end up with subluxation. That's why nowadays we are seeing more and more of these cases. Now, the other thing is, I think for the last 10 to 20 years, there are many patients who undergone cataract surgery at a younger age for many reasons. So these patients are still living active lifestyle, and occasionally they will come in with a subluxation lens after injury to the eye. Okay. Now, actually, I expect to see a lot of elderly presented with subluxated of IOL, but not really that many compared to the other group, because I think, this patient may have a pseudo exfoliation many years ago when they had the cataract surgery done. That time the capsular bag probably is intact, the zonule is still strong in holding the intraocular lens. But if they live long enough, gradually, this zonule get weakened, and slowly the lens gets subluxated. We don't see so often with this group of patients. I think likely because they are old, some of them may not keen to come to seek opinion, or may not want to do anything to the eye, even though they are not seeing so well. So these are some of my collections of subluxation of lenses. As you can see, some are not that obvious unless you dilate the pupil, then you can see the lens is displaced either to the left or to the right, or slightly to the bottom. Of course, the obvious one, you can actually see the lens capsular bag complex came forward to the anterior chamber or behind the pupil. The very obvious one, of course, you can only see the edge of the lens hanging around the pupil. And all kind of lenses, can have an incidence of subluxation, whether it's a 3-piece lens like this, a single-piece lens, monofocal toric lens, or even a multifocal lens here. So when a patient come to us with subluxation or IOL, what are the complaints? Most of the time is a complaint of sudden loss of vision. Okay, like when the lens is not covering the visual axis, they will have this complaint of sudden loss of vision. If the lens is still covering the visual axis, then the complaint may be different. They'll complain of fluctuation of vision, especially when they lie down, they say they can see better because the lens moved to cover the visual axis, and then they say when they're in a sitting up position, the lens actually will probably move towards the position of drop down and not covering the visual axis. Then they find the vision is poor. Or when they feel that, when they move their eye or their head, they have this sensation of fluctuation of vision. Okay, that's the symptoms. So when we examine the patient under the slit lamp, what actually do we see? Of course, the obvious one where the lens is almost dropping, then you may not see the lens with a non-dilated pupil, so aphakic. Okay, you may actually see a displaced IOL like what you are seeing here now. Of course, the anterior chamber usually will appear to be much deeper than normal. If you ask the patient, if the lens is still there, and if you ask the patient to move to the left or to the right, or you can actually, or blink the eye, even to blink the eye, you can actually see the lens move excessively. Okay, so that's called phacodonosis, and then of course, the iris also may move excessively when the patient moving the eye left or right. So that's called iridodonosis. Now, the management actually of subluxated IOL begin with the examination. Okay, we need to evaluate the capsular bag under the slit lamp. Now, it's important to try to find out whether the anterior capsular bag is intact or not. If the anterior capsular bag is still intact and the lens is actually subluxated through a rupture bag and so on, then it is good where it's the approach to this may be different already. Okay, so if the anterior capsular bag is intact, maybe the surgery is much easier by just removing the subluxated lens and implant a 3-piece lens into the sulcus instead of trying to fixate the lens after removing the subluxated lens. We also wanted to have a guess of the the lens material. Is it a foldable lens or is it a rigid PMMA lens? That's change your approach when you need to do the surgery for the patient, because the incision wound will be different. The lens that you prepare will be different as well. Okay, and also you wanted to know, if possible, the types of IOL that is subluxated. Is it a monofocal lens, a toric lens, or the multifocal lens? If it's a monofocal lens, then it's quite straightforward. You just have to, replace a secondary implant with a monofocal lens. Now, if it's a toric lens, then you probably have to explain to the patient that after the surgery, the patient will need to wear glasses to correct the astigmatism. It's not easy to perform a secondary toric implantation, in my opinion. Okay, multifocal implant is tricky. Okay, now if the patient, you get a good history from the patient. If the patient, not happy with this multifocal lens to begin with before the subluxation, then it's a good news because you're going to replace this multifocal lens with a monofocal lens, and most of the time patient will be happy. Now, if actually the patient is happy with this multifocal lens, then perhaps it will be a dilemma. You may have to spend a lot of time in counseling the patient. So what important most here is counseling. Okay, like testing for the COVID-19. You have to explain to the patient this potentially is a complex surgery. The calculation, the estimation of the lens power may not be as accurate as a primary procedure. It's not commonly performed surgery, so the outcome may be less predictable compared to the previous lens that was implanted. So Now you have to, when doing implanting a multifocal IOL as a secondary procedure, you have to make sure you do a nice job. The IOL has to be very well centered. I have actually done at least 2 of these procedure, replacing a multifocal with a different type of multifocal, and I think both the patients are very happy about this. Now, the only approach management for this kind of problem is through surgery. Okay, so dealing with subluxated IOL, most of us actually are facing 2 very unfamiliar scenarios. Number 1 is actually dealing with the subluxated lens. Okay, are we going to remove it, reposition it, or suture it? And again, we don't normally hear many people talk about how to deal with the IOL. That's because there's no standard way in dealing with a subluxated IOL. You know, the lens can be subluxated in many manners. So that's why there's no standard way in doing this procedure. Whereas when it comes to implanting, secondary implantation of IOL, you know, you can actually put in an AC lens. Of course, nowadays, most of us do not want to put in an AC lens because of the availability of other technique. As you know, of course, you know, there will be some patient, you know, who had a anterior chamber lens implanted for many years, and you know, the eye still looks good. However, there are actually many cases, you know, come with complication from the anterior chamber lens, such as UGH syndrome, chronic iritis, secondary glaucoma. Of course, in worst scenario, decompensation of the cornea. Now, iris fixation can be either performed using a Prolene suture or iris core lens. You know, this again, is performed by some of the surgeons as a secondary implantation of choice. You know, when I look at these eyes, you can actually see the big movement of the iris holding on the lens. So, you know, in my opinion, you know, this lens definitely tends to have, you know, chronic iritis, and there is also a possibility of causing corneal decompensation. So then the next option will be the scalar fixation of lens, which I'm going to go through with you afterwards. Now, to share with you, if I wanted to do a scalar fixation of intraocular lens, this will be my essential instrument to have. Okay, a 25G vitro forceps, and or with a 23G intravitreal forceps. Okay, I can have 2 of 25G, or 125G and 123G. Why I put out the 23G is because you know, it's a cheaper intravitreal forceps. You know, for your information, these 2 are the disposable type, supposed to be single use. If you are able to EO it, you know, can use it for a few times without any problem, and then save you money from buying the micro forceps, which can be quite expensive. Now, the other essential tool to me in performing this surgery is a reverse Sinskey hook. That I'll show you why it's so essential in this procedure. So now I would like to share with you some of the videos on subluxation of removing of the lens first. Okay, now this is you can see this lens is actually resting on the mid anterior vitreous face. When you start to do vitrectomy, you can see how volatile is the lens, and you also can see that, you know, I had an infusion on to support the eye with a reverse Sinskey hook. This is actually a subluxated, likely to be an M-Vista lens. So I'm supporting the lens to prevent it from falling back again, and try to move the lens forward into the anterior chamber. So you see this a reverse Sinskey hook. You can hook the haptic easily. Now, this is where the intravitreal forceps come in handy. Hold the capsule, support the lens, and with both of this instrument, I can bring forward the lens into the anterior chamber. Then you are quite safe right now when the lens is in the anterior chamber. Next, what I will do is, you can see that I use a reverse Sinskey hook to pull out the haptics. Okay, then enlarge the wound, okay, to a 3 millimeter. I'm a 2.4 millimeter incision phaco surgeon. So this is a blade to enlarge the wound to about 3 millimeter, holding the haptic, and then use the other hand, your dominant hand, use a St. Martin forceps or a cornea forceps, to extend into the anterior chamber, locate the optic, this is a haptic optic junction. Okay, show you here. Go in, catch the optic. The point of catching it has to be about 1 to 1.5 millimeter into the body of the optics in order to have a good grasp of the optics. Okay, now with this, you can gradually, slowly pull the lens out from a 3 millimeter incision without cutting the lens. Okay, now another case to show you again. This lens also subluxated quite badly. It's probably hanging somewhere. When I do a vitrectomy, you can see the lens move to one side, almost cannot see it. Now this is actually a Sinski hole. So I catch the capsule, the capsular bag, and if you look carefully, there's 3 dots in this lens. So this is actually a toric IQ lens. Again, with 2 instruments. One is a Sinski hole, one is a reverse Sinski hole. And again, I also support this eye with what you call that, anterior chamber maintainer. But at this point of time, okay, the other point I want to stretch is that you must always fill the anterior chamber fully, adequately, with enough viscoelastic. Okay, this is not only to protect the cornea, but also protect the iris. Okay, you do not want to do a good surgery and end up with a decompensation of the cornea after the surgery. Now, removing a subluxated intraocular lens has a lot of maneuver in the anterior chamber. So if you do not put enough viscoelastic, definitely there's a lot of touching accidentally, unintentionally on the cornea or the iris and cause damage. So now, again, using this true instrument, I manipulate and push the lens forward into the anterior chamber. Again, trying to show you using, I actually tried to pull the haptic out, but actually the wound wasn't extended. So I now extend the wound to about 3 millimeter incision. And, you know, you should pull out the haptic first, but in this case, I did not do that. You know, I just catch the optic at the optic haptic junction and pull the lens out to a 3 millimeter incision. So here the first take-home message is you can actually remove a foldable lens through a 3 millimeter incision without cutting the lens. Okay. Now to show you another case, but this is actually a rigid PMMA lens. So that's why I do I open up with a scalar tunnel incision and large tunnel incision, which measure about 6 millimeter at least. Now look carefully, entering the AC with a keratome, you can actually see that when the vitreous come out from the wound. Now these are some of the scenario you will see actually, even though the lens, the subluxated lens initially seems to be quite far away, but when the vitreous start coming out from the wound, quite frequently the lens actually float anteriorly, and it's easier for you to remove after that. All right. So next case, okay, due to time constraint, I'm going to pass this one. Actually, this is again trying to show you a 3-piece lens. Okay, you can see this is blue PMMA haptics, but unfortunately, I didn't realize that this is actually a 3-piece PMMA lens. The optic is actually a PMMA. You can see actually the optic haptic junction, they appears different from the foldable lens. Okay, now due to shortage of time, I'm actually speed out this thing. You know, when I go in with a forceps, then I realize that, you know, the lens is hard. Yeah, the optic is hard, and you can't cut the lens with a cutter. So you have to really enlarge the wound to remove this lens. Okay, now the next one is, okay, and next one is also a foldable lens, but this is a 4 haptic foldable lens, likely to be the aqueous, you know. Again, I couldn't see initially I couldn't see the haptics clearly because it's actually wrapped up, you know, wrapped up by the capsular bag, and I got difficulty in judging, you know, the where is the point that I'm actually holding on the lens. So in this particular case, you can see that sometimes you can have problem by you know, trying to pull the lens out this way, because you know, like in this case, I just show you that I try to pull the lens in my usual manner, but I actually did not catch the lens deep enough. You see, I'm still catching the haptic. So when I try to pull, and realize that by trying to go in further to pull the lens, you know, still is not deep enough on the haptic. So on the optic, so it tear the haptics. You know, I try on the other side again. Unfortunately, you know, it just tear the haptics. So now in this case, luckily you can see that I actually make a limbal relaxing incision here along the axis of my incision, because this eye so happen to have a pre-existing astigmatism. So I'm actually making limbal relaxing incision here, and I have no problem in making this wound larger to explant this lens. So I actually enlarge the wound to maybe 3.5 or 4 millimeter incision, and this time around have a good view, catch your lens properly, and you can actually pull out the foldable lens. Now this is an interesting case I want to share with you. This is actually a plate haptic lens. If you look carefully, you can actually see that the lens is not very clear. Okay, you know why? It's because the lens is calcified. Okay, so you can see I already make a 3 millimeter incision corneal wound here, and I get a special holder from the lens company. And again, you can actually use a San Martin as well. Okay, I've tried with San Martin as well. Again, go catch at the optic haptic junction through a 3 millimeter incision, a plate haptic lens. You can slowly, gently pull the lens out. Okay, so this is what I'm trying to show you. Due to shortage of time, I'm going to bypass this one. I'm not going to show you that one. The next is explantation of the lens and sulcus fixation. Why sulcus fixation? Again, this is one of the you know, I have shown earlier picture where the anterior capsular rims was intact during the examination. So again, the lens is repositioned, move forward to the anterior chamber with a reverse Sinski hook, and then you can see that I first must always, you can see I put in viscoelastic to deepen the anterior chamber, protect the cornea, pull the haptic out with a reverse Sinski hook through the wound. Then hold the haptic with one hand, corneal forceps. You can go in with a San Martin, catch your lens optic haptic junction properly, a bit into the optics, and then pull out from a 3 millimeter incision. Okay, after that you can do vitrectomy, implant the lens. Now my way of implanting a lens into the sulcus is that I always use a 3-piece lens, of course, and inject the lens into the ankle, okay? Not straight directly into the sulcus. That's because this lens, especially the haptics, when they open up, it can be a maneuver that you really need to be careful, because otherwise this lens, the haptic may actually push on the zonule and cause zonular dehiscence. So the safer and the more gentle way in implanting this lens is to first insert this lens into the anterior chamber angle in the anterior chamber. Okay, so I implant this lens. You can see I inject this lens, then I rotate the lens with a Guggen hook and a Sinski hook. So move both the haptics into the anterior chamber, and then you can fill up the use a viscoelastic to enlarge the distance between the iris and the capsule. Then you will use a Guggen hook or any hook that you are happy with to down in the lens, okay, in a very controlled and more gentle fashion. You can see here the haptics been down in one side and then the other side. Then after that, you can actually tuck in. In this case, I do an optic capture as well, okay? Right. So next is trying to show you scalar fixation of IOL. So what is the advantage of doing a scalar fixation of IOL? Now, you see, when we when we do this procedure, then you know, we are putting the lens back into the natural anatomy of a crystalline lens, okay? And there's no damage to the anterior chamber angle. There's no distortion of pupil, unlike the iris fixation of the lenses, where whether you use a suture or iris core lens, occasionally you will see distortion of the pupil. And this lens is far, far away from the cornea, so there's no risk of leading to cornea decompensation. Of course, it has its own disadvantage. It can cause a reverse pupillary block, and the optic can be captured on the pupil if you know, in some cases. So when you perform this scalar fixation of IOL, it's best to do a PI, okay? Either one PI, and some patients may need actually 2 PI to prevent this from happening. UGS syndrome, high incidence of cystoid macular edema, and the techniques are a little bit more challenging. That's the disadvantage. Now, there are basically 3 ways of doing a scalar fixation. You can either create a scalar flap for the suture. You can do the Agawa glue or the modified technique, which I'm going to show it to you, or Yamane, which is going to be shown by Dennis later on. Okay, I do have some time, I think. So a scalar flap procedure is one that I use to suture a rigid PMMA lens, okay? Now, as you can see here, this is a CZ70 lens specifically designed for scalar fixation, okay? Because it comes with eyelets on the haptics for suturing. It's a large optic, 7mm. So it's very good for eye that have decenter or irregular pupil, and very forgiving for tube, okay, because it's a large piece of lens, and the surgical technique is not too difficult. This kind of procedure actually hardly performed nowadays in my hand, and I was told that I think that my time is quite short, quite lack of the time now, so I jump straight to the other scalar fixation lens using a foldable lens. Okay, now this is a modified Agawa method that I'm going to show you. Now you can see the lens subluxated in the anterior vitreous face. The most important what you call it, the steps in doing a scalar fixation lens is actually the marking of the site of incision, okay, for sclerotomy or for the needle to pass through. So it's very important to mark the eye exactly using, like, you know, a cornea marker that I showed you just now, a cornea marker, mark it exactly at 180 to each other, opposite each other, and every single point that you mark has to be very exact in order to get a accuracy to prevent the lens from decentration and also tilting. Okay, after marking, I'm going to show only one side of the preparation for the surgery, because the opposite side and both sides are actually the same. So I mark about 2 to 2.5 millimeter away from the limbus, and then I make a slit incision. The depth will be two-thirds of the sclera thickness. Okay, two-thirds of sclera thickness. Not too shallow. If too shallow, then the haptics will be exposed. So you want it to be buried under the sclera. So make a slit incision of two-thirds of that parallel to the limbus, measuring length about 1.5 millimeter. Okay, so you stop short at the point where you make the incision, make the marking. Then I use a 30G needle, go through the end of the slit to make a tunnel. Okay, this tunnel will later be used to bury the haptics. Make two paracentesis next to the marking point. Then cornea incision for lens implantation, or in this case, I'm actually using the same lens, so I'm not making a very big wound. As you can see, you know, sometimes this can happen. So get ready with your forceps into the eye, and then go for a vitrectomy, because there are a lot of vitreous pushing the lens down. Once you start doing vitrectomy, as you can see, gradually and slowly the lens will actually come forward. Okay, so this is a time you should get ready to catch the lens. Okay, catch the lens, do vitrectomy, and then reposition the lens into the anterior chamber. Reverse scene skill, again, it will be very timely, very helpful in reposition the lens in this scenario. So first thing is to reposition the lens into the anterior chamber. Okay, and then vitrectomy, clean up the eye properly, and reposition the lens haptic. This is the position that I want to show you for the ease of sclera fixation of lenses. Okay, make the haptics get next to the sclerotomy site. Okay, use a of course, you have to make a sclerotomy with a 25G needle first. After that, then only your 25G intravitreal forceps can get into the sclerotomy. Okay, I've already done with the needle, so I go in with a 25G forceps. You have to use 25G for this, and through the cornea, you can actually use the 23G intravitreal forceps. The key point here is catch at the tip of the haptic only. Okay, only the very end tip. Okay, so that you won't cause a distortion or kinking of the haptics. Then you, in a controlled fashion, you slowly, gradually pull out the haptic. Okay. Now, so happen this haptic drop down to a position that is quite accessible with just going in with a 25G forceps. So I can just go in, catch it, and pull the haptic out. Okay. As long as you don't yank the haptic out, usually you will not cause the other side of the haptic to go back to the vitreous cavity. So this is the part where you tunneling the haptic into the sclera tunnel that you created earlier. How much to push the haptic in depends on the centration of the optics. So always watch the centration of optics. You can pull, you can push, until the haptic is centered. Then the next thing I do is, once it's center ready, I may close the slit wound with 10-0 nylon. This may or may not be a necessary step, but as for peace of mind, most of the time I would just do it. Then you close up the conjunctiva as well. Okay. So using a new IOL. Just now actually is a video to show you using the same IOL. So perhaps I also show you this video where I can actually, this is the case that I show you how I remove the aqueous lens. Now, okay, now this is what I want to show you. Now, implanting new 3-piece IOL into the eye. Again, I just like the earlier video that I show you, I will always insert the lens into the anterior chamber first, okay? Into the anterior chamber, like in this case. Then I will rotate for scalar fixation or even for sulcus fixation. I will rotate the lens in the anterior chamber and put the lens into this position whereby the haptics is close to the sclerotomy. Make sure the anterior chamber is well filled with viscoelastic. Again, I always like to stress that. This wound is large, so I suture the wound first. And again, the globe is actually quite firm and what you call that, in shape because of this infusion. So now again, this is to show you going through the sclerotomy with a 25G forceps. Now, if you do not have a infusion, pars plana infusion or AC maintainer, you'll find that this maneuver may be difficult, okay? And also it will lead to a lot of distortion of the whole globe, cornea, and so on. It may cause a lot of tissue damage by not having an infusion. So this is again a handshake technique. Of course, you need a bit of practice in doing this. But the trick is catch the haptic really at the very end in order to pull it out nicely. So this drop, I can't catch it properly, so I redo it again. Okay, now because the lens is actually in the AC, so I push the lens down. This is because this happens. This eye is has a very small pupil. Okay, so again, gently and slowly pull the haptic out in a controlled fashion. Okay, after one haptic is out, then we'll proceed on to the other side. It's the same procedure. Whether you're seeing me doing the 1 case or 10 cases of scalar fixation, the steps are actually exactly the same. So now this is to pull out the haptics. I fast forward a little. Again, I want to show you this because sometimes if you are not really catching the haptic at the very end tip, you can actually cause a bit of distortion. Okay, you see this haptic is kinking a little bit, and it's actually not easy to try to straighten it back. So if you find difficulty in burying this crooked haptic into the tunnel, if this distortion area is very short, you can actually just use a vinyl scissors to cut it off. Okay, and then then it's easier for you to tunnel the haptics. So you do the same thing on both sides, adjust the length, and then okay, so this is the other side. Once the other end is inserted already, you do the same thing, push it into the tunnel. How much to push in? Again, you must always go back to the optic check. In this case, I have to use a hook to push the iris away to examine the centration of the optics, and then suture the wound if you think you want to have a more peace of mind. Okay, now I wouldn't touch on the Yamane technique that will be touched by Dr. Dennis, but I actually have also started Yamane technique, long time ago, tried for quite a number of cases. But I find that in my hand with the type of IOL that we have, I always had some problem. Okay, so the incidence of problem is much higher than the scalar fixation that I had shown you. So I have now stopped doing this unless and until I have this CT Lucia lens with the PVDF haptic. What is the difference? I'm trying to show you here. The 3 pieces lens that we have now in Malaysia, they all come with, no matter what brand that you can get, they all come with PMMA haptics. Okay, now with a PMMA haptics, this is what happened. The memory is very poor. So if you accidentally bend the haptics, it will not go back to the normal position. And if you try a few times trying to manipulate and adjust the haptic, you see this is what happened, it will break. Okay, now, so it's very, risky to use this. You have to have a very good hand and handling really in good care. Otherwise, they also can cause distortion at the haptic optic junction. Now, this is actually what Yamane used, in his surgery, and also this type of lens is actually used in the Europe and US for this Yamane technique. Just to try to show you how robust is and how tough is this haptics. This is a PVDF haptics. You can twist, you can bend, you can do all sort of maneuver with this haptic, and you can just go back to like a normal shape. Okay, it won't break easily. So this is actually I'm waiting for this lens to come into Malaysia market. It's going to come in, as promised by Zeiss for many months already. I'm still waiting. So once this lens is available, I'm sure I will restart and try out the Yamane technique again. Okay, so this will be my last slide. So just in summary, I hope you have this some of these take-home messages with you. Now, if you are keen to do something like what I've shown you, the intravitreal or microforceps and the reverse cynskill hook are actually very essential to have, okay, in order to perform the surgery. I have also shown it to you that foldable IOL can be removed to a 3mm wound without cutting, whether it is a 3-piece, whether it's a single piece or a plate haptics or four haptics. You can actually remove all this through a 3mm wound. And most IOLs, no matter how severe they look, unless they already dislocated, otherwise in my hand they will not drop onto the retina during the surgery. So you can maybe be assured on that in doing the procedure. Worst scenario, of course, you just back up the eye and refer to a retina specialist. Please use adequate viscoelastic to always protect the cornea and iris. You do not want to do a successful surgery intraoperatively and then the next day patient come back with a very hazy cornea, and months down the road the cornea become decompensated. Okay, AC maintainer or infusion with a trocar are very important to maintain the integrity of the globe, so that when you are doing any maneuver in the anterior chamber, things are very stable. The techniques, to me, actually, it's not too difficult to master. What important most is you must have the proper instrumentation. Again, like Dr. Dennis said, watch a lot of videos. Of course, the best thing is to see a surgeon real life in doing the surgery. That will actually helps a lot as well. Okay, so thank you for your attention.
Thank you very much, Wai, for a very clear presentation and very good videos. Okay, there are a couple of questions, but if it's all right with you, I think we can let Dr. Dennis Kong speak first, talk about the Yamane technique, and then we can proceed with the questions all together. Is that okay?
Yeah, sure.
Yeah. Okay, so Dr. Dennis Kong will now speak, and he will share some tips on how he does the Yamane IOL fixation technique.
Okay, thank you, Vicky. Okay, I'll talk about the modified Yamane technique. Make slightly easier, something disturbing. Okay. Most important is, like YY say, is marking the so that you are symmetrical and your lens will not be eccentric. So usually I sit on a temporal position, and so it's 2mm from the limbus, and then 2mm again from the second marking in the anti-clockwise direction. I find that sitting on the temporal position, the view is generally better. So again, on the other side, likewise, 2mm from the limbus, and then 2mm from the second marking in the anti-clockwise position. Injecting the lens is a 3-piece IOL with PMMA haptic. They are doable, but like YY said, you have to be much more careful because the PMMA haptic more fragile. Now I'm needling, doing the tunneling, and there's counter pressure with the cotton bud on the other side. So you go about 2 millimeter, roughly to your original marking, and then you dive into the vitreous cavity, just posterior to the iris plane. Then you bring the tip of the needle into the AC. Okay, then you use a VR forceps, a serrated VR forceps. I usually just use a 23 gauge forceps. And then I think the one thing I always find is always easier to bring your needle to the haptic rather than the other way around, because I do see surgeons struggling with trying to bring the haptic to the needle. You see what I mean? Because there are two of them, you can move either one, and it's always easier to move the needle. Now I'm cannulating or docking the haptic into the ball of the needle. So you just go slowly, and once you are far enough, then you externalize the haptic, pull in the direction that you came just now, not radially all the way. So you sort of go radially a bit, and then anti-clockwise. So I will cauterize the first leading haptic. I think it's a better technique in my hand. So you have secure one side, and now you're doing the second more challenging trailing haptic. Again, tunneling 2 millimeter, and then diving into the vitreous posterior to the iris plane. I'm sorry about the centration of the video, but I think you come up to be a bit better soon. So with the other haptic already out of the way, I think it gives you a better exposure. So grabbing the trailing haptic, and I've obviously grabbed a little bit too far from the end of the haptic, so I have to let go and then re-grab, struggle a little bit. But you can see the haptic, there's quite a bit of distortion. So I've got into the AC and then just bring it forward and dock it into the 26 gauge needle. So again, thread it through till at least it's halfway, and then externalize in this radial manner, and then anti-clockwise basically in the direction that you came originally. Don't just go radially all the way. You can. So now I'm cauterizing the haptic. I do cauterize a little bit more than usual because as you can see, I'm using a 26 gauge needle, which is slightly bigger. So I cauterize a bit more. Now I'm just injecting some triamcinolone into the AC to highlight any vitreous. And now I'm tucking the haptic onto the sclera flush. I did do a peripheral iridectomy. I think it's important to prevent complication with iris block and so on. So I'm going to present a few slides about the Yamane technique. Okay. So as I say, I sit in a temporal position. Always give adequate LA. I mean, most patients would think that the less pain there is, the more skilled as the surgeon is. So the amount of pain is inversely proportional to the skill of the surgeon. So always give a little bit more LA than you need, and the surgeon and the patient will be very thankful for that. I do my marking not in the 3 and 9 o'clock position. I actually sort of do it slightly obliquely, about 4 and 10 o'clock position. I think it gives slightly better exposure, and you also avoid the vertical blood vessels, and probably less risk of hemorrhage. As I said, I use a 26 gauge needle. That is a technique that is slightly different from, of course, very different from the original Yamane technique, in which they use a 30 gauge needle, but those are actually thin wall needles with, so the bore of the needle is bigger. You cannot use just any 30 gauge needle. I think most people do use 27 gauge needle, and that is doable. Always make two extra paracentesis, sort of next to your original, your main incision where you're going to implant the lens. That is very important, just in case you have to come from a different direction to maneuver your haptic into the needle during a cannulation or docking procedure. Always use an anterior chamber maintainer, like YY say, to maintain the pressurize the globe so that it's easier to do your needling, your tunneling. I think a lot of, I do see quite a lot of videos, and there is some surgeons do always try to bring the haptic to the tip of the needle. I think that is a more difficult maneuver because moving the tip of the needle is a lot easier than moving the haptic, because the haptic is attached to the optic and there's another haptic. So if you try to move that too, it's always very much more difficult, and you have to distort the haptic a lot. So remember, the tip of the needle is much more mobile, and you can really position it wherever you want to. A good alignment prior to docking is essential, especially when you are using PMMA haptic, because the tip of the needles are very sharp and can easily cut and damage your haptic, resulting in distortion or even breakage of the haptic. Externalization of the leading haptic and cauterization is done. So I do it sequentially. I'll do externalize the leading haptic first, cauterize it a little bit more than usual because I'm using a slightly bigger needle. And once I secure that, I will move on to do the same process with the more challenging trailing haptic. The trailing haptic is actually more challenging because of the space constraint and also and so on. Then I'll do a peripheral iridectomy to prevent pupillary block issues. So let's remember to move the tip of the needle to the haptic rather than the other way around. It is a lot easier to maneuver your needle. I think for those of you who have tried the technique, you will realize that. So I do a sequential technique rather than a classical technique in which actually the cannulation is done and then you actually drop the leading haptic and the needle down, and then you do repeat the process on the trailing haptic, and then you externalize them, those two haptics simultaneously. But I do a sequential technique. I think it improves exposure because one side is already out of the way, and you just have to deal with the more challenging side with a better exposure. So there's better exposure. I think it's easier to do. Also, I think I always worry about the risk of the leading haptic and needle left dangling in the vitreous and possibly damaging intraocular structures. I think with the sequential technique, you avoid that risk. Some degree of ambidexterity is needed in doing this procedure because obviously, when you're doing one side and the other side, you have to reverse what you're doing with your hands. So you need some degree of ambidexterity. Sharp needle tips can easily damage or even break haptics. So you have to be very gentle, especially if you are using PMMA. And of course, the ideal lens, like YY say, is the one with the PVDF haptic, but generally not available, very difficult to get in Malaysia. So I've always been using the PMMA haptic, and it is doable, but you have to be more gentle. Stay safe and thank you. That's the end of my talk. I think we are open to questions now.
Yes, thank you, Dennis. Yeah. So there were a few questions for YY. YY, do you want to answer your questions live?
Can, no problem. You know, there's one question asking me about, you know, for Maylene actually, whether the haptic disappear into the sclerotomy. I don't really understand what this should mean by disappear into the sclerotomy. Does it mean that when you pull on the other side, the opposite haptic actually get pulled inside? Probably, I think she probably mean that. Okay, so that's why I say you have to pull out the haptic very gentle, slowly in a controlled fashion, so that you don't yank out the whole haptics, okay, on one side. If you yank out the whole haptic from one side, then of course you may pull the entire optic to one side and the haptic may follow through. So the haptic that came out from the initial sclerotomy may get pulled back into the vitreous cavity. But don't worry, it's the same technique again. If you accidentally pull the optic too much until the haptic drop back into the vitreous cavity, then you again go back to the place where the haptic drop into the vitreous. You do the handshake technique again to pull out the haptics. Okay. Now, I think this is what you mean, right? I hope I have answered your.
Okay. I think maybe we will unmute let Maylene speak 1 minute. Yeah.
They want to push into a scare tunnel. Okay, now.
Yeah,
now
question
in order
different.
to, yeah, in order to be on to know, because once you actually make the scare tunnel, later on you actually couldn't see the tunnel anymore. So in order to know where is a scare tunnel, when you bury your needle, the 30G needle, you must actually bury at the end of your slit incision, okay? So that it gives you a guidance when you push the haptic along the slit tunnel. You know, it will lead you to this tunnel. You can't actually see the tunnel after you make it because the scale will collapse and you couldn't actually see it. There's no opening there. That's why you have to do at the very end of your slit incision, okay? So that when you move your haptic along this slit incision, it will lead you to this tunnel, and then you can tunnel it.
Okay. Yeah, earlier you had a question from Dr. Makandu as well. What was the final visual status following the removal of the subluxated lens and the implantation of a new lens?
Yeah, it should be good unless there's other ocular pathology. If there's no ocular pathology, the patient should see well.
Yeah. Do you take any extra precautions? Because obviously this involves manipulation and there'll be a higher chance of CME, cystoid macular edema. So what are the extra precautions you might take for such a case?
Intraoperatively prevent hypotony. The other precaution is there's a lot of maneuver in the anterior chamber, so a lot of viscoelastic to prevent any accidental damage to the cornea and the iris. Post-operatively, always use Nivanek. Probably you want to use more than 1 month. And then intraoperatively, you should do a PI to prevent reverse pupillary block. These are the additional things that you do for this kind of procedure.
What about eye drops? Do you use NSAIDs or longer steroids?
The non-steroidal is a standard, minimum of 1 month. Probably can use. Depends on on the how the patient improve from the surgery. The thing is, cystoid macular edema. Sometimes I have probably 2 patients who develop cystoid macular edema 3 or 4 months after the procedure. So it's not like immediately a month or immediately after the surgery. They all had these non-steroidal NSAID drops for the first 1 month. I usually just give them a bottle. If they are high risk group, like diabetic patient, maybe I'll give them 2 months the most. But once they develop a CMO, then of course I'll treat that accordingly.
Can I ask the my two fellow speakers, what position do you sit when you do your scleral fixation technique? temporal, superior, or?
Again, I'm, like you, I feel more more comfortable in sitting temporal because I'm a temporal phacosurgeon mostly. And, I usually do temporal, whether it is through using a foldable lens. That means my incision is about 3 millimeter, or even putting in a CZ70, which is have to go open a scar tunnel of about 7 millimeter. I also can do it in a temporal position. But again, when I have to make a large incision like this, I often look at the patient pre-existing astigmatism, see whether there's any position that I can help to reduce the astigmatism, with this procedure. So I may sit superior again, because a lot of time this patient may have some other procedure done earlier, and they may be easier or better to do superior, then I'll do superior.
And Dennis, yeah, I think I've done it both ways. Let's say if it was a planned procedure, I tend to sit superiorly. I found that because in some of our Asian eyes, the pupillary aperture is quite small. I find that if I sit temporally and I try to go either 12 and 6, or if you do 4 and 10, sometimes I don't get enough exposure, and I have to distort the eye a lot to try and get the needle into position and go in with it. So if you have your nasal and temporal sclera there, you got more space. But I've also done it in cases where I'm a temporal surgeon and I have a problem on the spot, so I tend to do a fixation on the spot. But if given a choice, I prefer to sit superiorly. I think there's no right or wrong way, but either way, whichever is comfortable.
I think there's no right or wrong answer. It's your preference, really.
Yeah.
And what about externalization, Mun Wai? You do it simultaneously, is that right, or sequentially?
I started off doing it exactly the way Yamane did it, and then subsequently, I also tried it your way. But I found that basically when I do fix the leading haptic first, as you see in your video also, there is a lot of torque of that leading haptic, because as you're bending to try and feed in the trailing haptic, they actually bends a lot. So I've ended up with some cases where you actually either completely distort the haptic or break it. So I tend to leave the needle in. So I've done that for the past, I don't know how many cases now. So I leave the needle in. And yes, I agree there is a concern as to where the needle is flying around, but I've not had trouble. And I find that, it seems to be easier because it allows the movement of the optic and the leading haptic such that the trailing haptic is more accessible. And then when I take it out, I would take out the trailing first and grab it, and then grab with this end and then pull out the other side. Because I've tried to do it both before, and one hand goes faster than the other, and the other one goes back in. So, yeah.
So actually, there is a slight sequential in some way, but not
sequential
as
in some way, yeah.
Yeah.
But I don't speed it first.
Yeah.
I think there were some questions for you, Dennis. I'm not sure whether Picky was going to ask you.
Some question. But before that, there was a question for YY.
Yeah.
YY speaks like a true corneal surgeon. You see, throughout his presentation, he emphasizes protecting the cornea, with viscoelastic and all that, okay? But he doesn't emphasize so much on the anterior vitreous and someone has actually asked Dr. YY Choong, is it advisable to do a limited pars plana anterior vitrectomy first prior to pulling out the subluxated IOL to prevent vitreous traction? And what would be a recommended pars plana anterior vitrectomy settings on the Centurion machine? My hospital does not have the trocar system for pars plana. Is it safe to perform a sclerotomy using an MBR blade and pressurize the eye with an AC maintainer instead? Yeah, so there's some concern for the retina and a peripheral vitreous base.
I'm glad somebody said it on my behalf.
Actually, if you have seen my video in explanting the intraocular lens, frequently when I open up enter the anterior chamber, I would actually do a vitrectomy first. If let's say the lens is at the anterior vitreous plane or tangling, at the pupillary edge, I actually will do an anterior vitrectomy first to remove some of the vitreous in the anterior chamber. But of course, I wouldn't do a complete. You have to balance here doing a complete, very core pars plana vitrectomy, and and also must watch the lens. If you do too much of vitrectomy, for all you know, you don't know whether the lens will drop just right in front of your eyes or not. So, while doing that, you see what I do is usually I watch the lens closely. Once I find that I have the ability to lift the lens up to the anterior chamber, I'll first lift the lens up, okay? After some vitrectomy, at least to remove some of the vitreous in the anterior chamber, okay, and at the wound as well. So after that, I will lift the lens up. In fact, of course, I did not show you all the vitrectomy that I do. Once the lens is in the anterior chamber, then you'll be very safe to continue to do more vitrectomy before you actually remove the lens. But again, sometimes if you find that there's not much of vitreous holding on the lens, you probably can just remove the lens. In my opinion, you can just remove the lens first and do more vitrectomy later. And with a Centurion, I think whenever I do a vitrectomy, I use a maximum cutting rate. I think it's 1,005 or 1,008, something like that. Okay, 5,000.
4,000. 4,000.
4,000. Okay, I use the maximum. I use the maximum cutting rate through the pars plana or through the anteriorly through the cornea incision. Okay.
Okay.
And you do a separate infusion.
Can I give the retinal surgeon perspective?
Okay. Yes.
For somebody who doesn't care too much about the cornea. So I think for what Lisa said, I think for me personally, I would try to do the vitrectomy first. So therefore, I always advocate a pars plana, because what I tend to do, like you said, why is trying to get the balance. So what I do is, if it's a subluxated lens, which in this case it is, so one of the principles of this kind of surgery is you need two hands really. You need to be comfortable doing bimanual things. There's a lot of maneuvering with both hands. So the one hand, the non-dominant, or whichever hand that is your non-dominant hand, has to go in through a paracentesis. Usually I use a micrograsper. I grab the haptic or grab the IOL first. So I hold that in place. Then your pars plana vitrectomy will go and cut around the IOL to free up whatever vitreous is entangled, clear the anterior vitreous area so that at least whatever vitreous that's communicating with the anterior chamber from the posterior chamber has been truncated. So whatever's left in the anterior chamber, you can deal with later. And then you bring the IOL in the front. So that's what I do. And for the settings, I think Centurion cut rate is about 4,000. I go vacuum around about 350 to 400. IOP for me is around 40 to 50, and the aspiration or the flow rate is around about 20 or just below. So you don't want to be too turbulent to stir up things. That's what I do for Centurion. And in cases, because I operate in another hospital where they don't have the Centurion, they have the Infinity. And the Infinity, the old one before they upgraded the cutter, the anterior vitrectomy cutter only goes up to 800, I think. The newer one goes up to, I think, 1,005 or 2,000. So I don't have trocar system there. So if you need to do it, by all means, open the conch, use an Ambiera blade, it's 20G, put in your 20G cutter, cut it, and then stitch. So yes, I think you can do it with the AC maintainer, because that's what I've done.
Well, I tend to, in a way, I think YY technique of, especially if you have a subluxed lens that you can hardly see, I think you should do an anterior vitrectomy through the limbus first, because that would decompress the anterior chamber, and then the lens will float up, even a cataract as well, or a fake, of course, a lens. I think in some way you have to start doing that first as anterior segment surgeon, secure your lens, and then try to deal with the vitreous subsequently, because you must get the lens, otherwise it drop and you have no chance. only one chance to bite the cherry. So I would do from the limbus first, and then subsequently, I agree that the pars plana position doing the anterior vitrectomy is much more logical, and probably you do a much thorough vitrectomy as well. I think there was a question to me from Prof. Melin. I saw in the chat. She was asking me how I bend the needle. I usually just use a big needle holder and just bend it. Roughly about 45 degrees. I don't think it matters too much, because you can always compensate by tilting your hand a little bit here and there. So I think it's not. I have seen some surgeons who describe, how to bend for the first needle and how to bend for the second needle. to me is a bit unnecessary. I'm not sure how about what about you, Mun Wai? Do you have a
Not really. I
specific
think
technique?
you use a larger needle holder, as you said, 30 to 40 degrees around that bend, and usually about 2/3 of the way up the needle. I don't bend it right at the hilt near the hub.
Yeah.
About 2/3. You don't need that long, really. And yeah, there's some descriptions where they actually try to bend the needle so that the opening is facing you to make it easier for you to thread the haptics for the leading one, and then the trailing one where the opening is away from you. To me, it didn't make that much difference because, like you said, we tend to bring the needle to the haptic. It's easier than the haptic to the needle. So either way, that works. There was a
And you
question
can
from
always,
YouTube, actually. Somebody was asking, I think maybe Dennis or YY, they wanted to know how you calculate your IOL power for scleral fixation. Is there a particular formula or a constant or whatever ACD number that you use?
for me, I generally, you know, I just use like as if we are putting into the bag, and I generally like to go a bit more myopic. I think in the modern world, myopia is much more useful in the sense that your handphone, your computer, and I think myopia is much more useful. So generally, I will err on the side of myopia. What about you, YY?
I've reviewed some of my cases. The earlier cases that I do usually is 2.5 millimeter away from the limbus. And then post-operatively, I noticed that the lens is actually sitting far more posterior position than in the back. So luckily, initially I also thought of this kind of problem. So I tend to make the patient choose the lens that's a little bit more myopic to begin with. And that actually may fit it nicely because the lens is sitting more posterior. Now I'm actually moving towards the limbus. I'm trying to go to a 2 millimeter incision instead of 2.5. So with this, I think I can just choose the lens power that's close to emmetropia. So you have to look into your result after a few cases, then you want to adjust accordingly.
I think there's another.
I just tend to use Barrett or people or whichever formula you're comfortable with, the Barrett Universal 2 or whichever you're comfortable with, and aim for emmetropia or slight myopia. That's what I would do, because if you end up with myopia, it's always better. So there's no specific hard and fast rule really to calculate the actual lens power. Yeah, Dennis, you were saying.
Yeah, I think there was some question about bottle height and so on. To me, I think it's just quite as important. You must get the eye firm enough so that it's easier to do your needling, because your needling need the eye to be quite pressurized so that it's easier to do. And I always counter pressure with the cotton bud from the other end. So that's my usual technique when I do the needling. Yeah.
There was a question for you also, Dennis, about how you ensure that the needle is 2 millimeters, before you tunnel into the eye. I think there was a question about that.
Oh, I didn't. Okay. How I ensure that I first, of course, you do the marking first on the conjunctiva. But sometimes during the surgery, when you're actually doing the needling, you've lost that marking. But it's because I usually try to put a depression quite, and a mark with a caliper. So sometimes you may see the mark, and then you roughly can see some bulge on the sclera, and then but sometimes it's a little bit by feel, I think, but I think if there's not too much chemosis, then you can see. But otherwise, I think some other people have actually do markings on their needle.
That's right.
They know how deep they've gone. Yeah.
I tend to mark the needle. I mean, you either use an ink mark, or you can just use something to scratch so that you know how far in you've gone before you turn. So I think that's easier.
I think that's a good idea. So you actually scratch your needle tip.
You can. I mean, people are concerned that the ink, if it goes inside, whether they will cause any problems. But I've used ink. I think no problem. But you can either use something else to just scratch the needle where the 2 or 3 millimeter mark you want, so that when you go that far, you know that you've gone. The tunnel is that long, then you can dive into the eye.
Then your preferred technique is also Yamane rather than the modified Agawa?
Yeah. I use the Yamane as a standard, yes.
Yeah, the advantage of the Yamane technique is you don't have to open the conch and it's not
lazy surgeon.
It looks more elegant, in doing the Yamane technique actually. But I have a few incidents where there's a distortion, tilting of the lens. I find this sort of incident is too high in my hand, so that's why I currently I'm abandoning doing this.
There was a question about what you do with exposed haptics.
Okay. Well, I've had exposed haptics before. It depends whether there's one where I just left it, to be honest, because it was subconj or at least maybe subtenon. So I left it. I mean, the patient was not complaining of any foreign body sensation. The lens was stable. So I left it, and it's not really caused a problem. But there's some where they do come too far out. And sometimes immediately post-op, I've had one where it was quite far out, and I realized that I didn't probably bury it enough. So on the slit lamp, I just pushed it back and buried it, and it was okay. If it was really exposed and you cannot manage it and you have to go back and cut it really, either you cut it shorter and then put the flange again and make sure it goes in, or you just bury it properly when you go back in again to OT, I think.
Okay, there's a question from Dr. Lee Long. What is the setting for cauterization? Question to Dr. Dennis. And then also there's a question from Dr. Tiong asking, has anyone seen endophthalmitis following the Yamane technique in the long-term follow-up?
The first question, cauterization, there's no setting. Those cautery that we use are low temperature portable cautery, and there's no setting. You just cauterize and look at the mushroom. When you cauterize, the other thing, you don't touch the haptic. You bring it to the very near to the haptic, and you just see it, mushrooming up or forming a bulb. And if you think that is large enough, that's good enough. There's no special setting to the cautery, but you have to use those handheld cautery, low temperature cautery to do the cauterization.
Yeah.
Are they single use? The ones that you use, are they single use?
Yes, they are single use, but there are tricks around, and you can recycle them.
Which company do you buy them from? Maybe you can share that, because most OTs will not keep that kind of cautery. And it comes in high temperature and low temperature models as well. So you have to make sure you don't get the wrong one.
Yeah.
No, even the high temperature can be used. Yes. Just got to be more careful.
Don't touch the eye.
Which local company supplies that?
Mandarin Optic do supply them, but they will sell in bulk, I think about a dozen or so. But I managed to get mine from some local hospital nearby. And my good friend, Dr. Peter Kong, gave me one as well. So I'm lucky.
Gave you one and you've been using it?
He was the one, Dr. Peter Kong was the one who introduced me to using 26 gauge needle to do the needling. And I have asked him very recently just to find out whether any problems with slippage and so on. So far, he has none. And touch wood, so far, I don't have any slippage because there is always a worry that you're making a bigger tunnel and there could be potential slippage of your haptic, even though I do try to make the bulb of the haptic a bit bigger than usual, yeah.
What's the longest follow-up on your Yamane cases? And have you seen any endophthalmitis?
Let me think, about a year or so. No, I haven't seen any endophthalmitis in my hands. I think there's, in fact, the day after, if you look using cider test and so on, I think there's no evidence of leakage. I think it sealed very well. I think there's no problem with that. And eye pressure usually pretty good. There's no hypotony. I'm not sure about the experience of my two other speakers. Yeah.
No endophthalmitis for my case. I have got some up to about almost 4 years now. So no endophthalmitis with them. And very stable. I think it's a learning curve, just like for any procedure. I always think that, I know everyone says this one's very elegant, actually looks very nice. And it's simple in principle, but it's not that easy to do. So there's a bit of a learning curve. I think my first probably 6 to 8 of them, I knew there are always those multiple problems and whether you want to persevere and fine tune things. I think it's worth it because I found that as so far anyway, it seems to be the one that gives me the most stability and the least messing around with the conch and all that kind of thing. So,
yeah, I agree with Man Wai. There is a learning curve. Watch a lot of videos and, see different techniques and think for yourself which one would be best suited to you before you actually try. And probably, it would be good if there's someone, you really have to talk to somebody or to find out what's their experience, I think YouTube sometimes is so heavily edited that it's just too easy. And actually, I find that when I review because I was doing my video, and I find that I learned a lot looking through my unedited video, because you see how you struggle here and there,
yeah.
and you think I could have tried this and done that, and probably do it better, And it's a learning. You do learn even from editing the video. I want to ask YY about. I quite like your pulling out technique of the single piece foldable lens. I do it as well. But have you ever tried pulling out a 3-piece, lens, and what's incision size would you make?
3-piece foldable lens?
Yeah, 3-piece foldable lens. Yeah.
As long as they're foldable lens, whether they're silicone or acrylic, I can actually pull out from a 3mm incision. They will just unfold by the wound. They'll just unfold, and you just get able to pull it out, because the diameter of the lens is either 5.5 or 6mm. So a 3mm incision or slightly larger than that, you're able to pull it out.
But don't you think that a 3-piece like the Sensor lens, that the haptic is actually more stiff, stiffer than the, for instance, the Alcon Acrisoft.
The haptic.
The optic is stiffer.
The optic, let's say for instance, the Envista lens is also harder. So when you're pulling the Envista lens, you got to be slower and more gentle. You can't pull out so fast like the Alcon IQ lens. IQ lens is soft. But Envista, you have to give it a bit of time for it to unfold within the wound, and then only you pull it out. Okay. So one advice for all the participants in this meeting is that whenever you try to start off with this kind of procedure, whether it's Yamane, whether it's the other types, the modified or Gawa method, you must have a standby 3-piece IOL with you. Okay, don't just get 1 piece only. You must have a standby just in case anything goes wrong with the haptics or the optics. You have a standby lens that you can replace and do it at the same time.
I think the other thing is wet lab. Well, I don't know whether with artificial eyes to do this, but I use pig's eyes. I think there's really that's something you should be able to do before you actually go into a human eye. There's a lot of wet labs for all these kind of things.
Yeah, I think if you can get artificial eyes, those not actually wet, artificial eyes that you can practice on. I think that is very good as well. Because anything that you practice on, your hand position, certain maneuvers, it helps. Practicing is very important. It makes perfect. I mean, even though it's not the real thing, but it still helps with your hand position, the way you grip the haptic and so on. Yeah.
So, Man Wai, there's a question for you.
Do we have
some
time?
tips for Yamane? Yeah, your tips for Yamane. Which are the most difficult parts that a beginner is likely to run into trouble with?
I find the trailing haptic definitely the most difficult part, because what happens then is, you can either, normally the traditional way that Yamane has taught it is through 2 paracentesis, so usually about 4 clock hours apart. And you have to find a sweet spot for yourself where you should actually put your hand so that you can actually bring your haptic to your actual needle easily. So the trailing haptic is always the most challenging. And having tried, either you exteriorize the leading first, you fix the leading first, or leave the needle behind. Or if you go on YouTube and you search Brian Kim, who's another surgeon in America, he would exteriorize the leading haptic through a paracentesis, which is directly opposite the actual main incision, to actually make it easier to put in the trailing haptic. So the tip for the trailing haptic, I feel, is once you got your needle in, you must use that needle to actually push the IOL optic. So you use the needle to actually engage in the junction between the trailing haptic and the optic, and subsequently push it towards the actual so-called inferior part, or the in the direction opposite your main wound. So that will present the trailing haptic to your left hand using a micro forceps through the paracentesis, so that you can then bring back the needle after you've grabbed it with the micrograsper to then feed it in. So that, to me, is the most difficult part, but the easiest way to actually do it is, of course, practice. But you have to be able to use the needle optic push, I find, to actually make it easier to engage the trailing haptic. But if you're failing that, then some people have gone through the main incision to actually try and grab the haptic to feed it in that way. But I find that if it's better if you're using an AC maintainer, but you tend to have a lot of instability in the anterior chamber because you're pressing on the big wound, and then there's a lot of fluid gushing out and the anterior chamber is unstable. So to me, that's the most difficult part. I mean, there are so many little things as you move along. So I think if you attend any of these courses, if you have a chance in future, whether Yamane is going to give one, I think a lot of its courses, you find that it goes to a lot of those small details which are actually important to get it right.
Yep.
Yeah.
Yeah, one final question for YY, right? When you pull out the IOL, is there any risk of a Descemet's tear?
Oh, that's why it's so important to fill the anterior chamber with good protection from the viscoelastic. Now, when you actually pull the IOL out, as you can see, what I do is once the St. Martin forceps, catch the optic at about 1 to 1.5 millimeter. So the lens actually is folded and conformed to the wound by the edge of the wound. Okay, it's just like a cartridge. Okay, yet when you pull the lens out, it's just like you are conforming the optics to a cartridge. So it will unfold within the anterior chamber. So if your anterior chamber is well kept with viscoelastic, it will not touch on the endothelium. So there will be no Descemet tear by doing that. And again, we are pulling the optic out from the wound. We are not pushing the lens into the eye. So the Descemet membrane tear incident will be much lower here.
Okay, does anyone have any final comments or questions?
I think why I always struggle with that technique to tuck the haptic. I've tried your technique as well. My Achilles heel is trying to tuck the haptic into the tunnel that I created. I really struggle with that somehow. So I even use 23 gauge needle sometimes to create a really big tunnel. But and then you try to look for it. It's quite tricky, and then you always worry about if you manipulate one side, you always worry about the other side, dropping into the vitreous and so on. There is always that worry. Yeah. So I do struggle with that technique, and somehow Yamane was a bit easier for me. I think it depends on, sometimes it depends on us. Different people, different, some techniques can come a bit easier for us, and some others you struggle. Yeah.
Okay. Well, if there are no more questions or comments, I think we can close. So it only remains for me to say a very big thank you to Dr. Dennis Kong for organizing this meeting, all the panelists for sharing their skills so generously, to Dr. Ben Ho for enabling this symposium, and of course to all of you, all the participants, for tuning in and participating in this symposium. So thanks very much, everyone, and stay safe, and I hope that we will go back to normal as soon as possible. But we should continue such webinars every now and then because it's very helpful to everybody and enjoyable. Thank you then.
Thank you.
Thank
you.
Bye.
Thank
Thank you, everyone.
Vicky, very good moderator, keeping all the men under control. and of course to all the participants as well. And of course my fellow speakers, YY and Man Wai, and also Benjamin Ho, who has been invaluable in giving us technical tips and advice, because you need the young ones who are more tech savvy to guide you. Okay, stay safe, and hopefully see you guys again next year. Take care.
Before that, I'm sure. Take care. Bye-bye.
Okay, bye.
Yeah.